Morning, everybody, and welcome to our session on value-based care and patient safety. My name is Terrina Govender, and I'll be moderating the event. I am the Director for Policy and Strategy at the Global Innovation Hub, and I work with Dr. Reem, our keynote speaker. The session is hosted by the Saudi Patient Safety Center, and it will run for an hour long. So we'll have a brief introduction from me, and then Dr. Reem will go into the keynote. And then we'll open it up for question and answers. So if you have any questions, please feel free to post them into the chat box, and we will answer them as they come in. I would also like to thank the Saudi Patient Safety Center for inviting us to talk about this really relevant and timely topic. And so with that, I will take you into an introduction into the Global Innovation Hub. So the G20 Global Innovation Hub for Improving Value and Health was born out of the Saudi Arabian G20 presidency. And we are membered by the G20 nations, 15 of them, as well as the WHO, the OECD, and the Islamic Development Bank. Our main primary mission is to accelerate the transformation towards value-based care. And we do this globally, and we do it through a number of methods. So we produce knowledge, we run collaborative experiences, we facilitate dialogue, and we see ourselves as a connector, an integrator, and an educator for all things health system resilience, health system strengthening, as well as value-based care. Since our inception, we started within the Saudi Arabian presidency in the year 2020, and we've worked with all the subsequent presidencies, and we work quite closely with the Health Working Group, given the nature of what we do, as well as the Joint Finance and Health Ministers task force. And so during the Italian presidency, we were mentioned in both the Health Working Group declaration as well as the Leaders Declaration. And we contributed to their agenda, specifically on value-based care and pandemic preparedness. Within the most recent Indonesian presidency, we continued that work and spoke quite closely to the elements of value within their pandemic preparedness planning. As I mentioned, we have several knowledge products that we've created over this past year, and one of them will actually be highlighted quite closely. It was a paper that we did looking at the drivers and barriers for value-based care in the Middle East and North Africa region, and Dr. Reem will be talking a little bit more about that. But some of the other things that we've done include work on provider payment models with the OECD, and several papers related to the G20 agenda. And in the upcoming year, we're going to work quite closely with Harvard University to continue the production of this very valuable body of evidence for value-based care. And so I would like to introduce my boss and colleague, Dr. Reem. Dr. Reem holds many hats. In this case, she is the executive director of the G20 Global Innovation Hub, but she also runs a national body within Saudi Arabia, where she's the CEO of the Center for Improving Value and Health, and they work at a national level. On top of all of that, Dr. Reem is also a consultant neurologist who was in clinic today and serves as the pillar lead for UHC for Saudi Arabia, as well as several national leader for several different working groups within Saudi Arabia. And she's just incredibly qualified and an excellent speaker on the topic. So I will hand it over to Dr. Reem.
Thank you very much. Thank you, Terrina. Assalamu alaikum. And it's really a great pleasure to be speaking to you as part of the WHO Collaborating Center of Excellence on Patient Safety. And I would like to start with a warm greeting to colleagues in the Kingdom and the MENA region and the EMRO region at large. And I would like to thank the organizers from the Saudi Patient Safety Center for their diligence and care for this session. So the idea in the coming half an hour or so, I will be speaking to you about the topic of value in health systems or high value health systems. I will be speaking to you about this and how it applies to the region, and we'll be linking this with the topic of patient safety and ending with a case study that could be used as an example. So value in health and care is a new model in which health systems are designed, where the focus is fundamentally shifted to focusing on the outcomes of the population health and care relative to the investment that's put in there. And the biggest investment that is put in there is in the human capital and the human resource in providing care for people in the population. The next slide shows the challenges that health systems are facing. There is, with time, a rise in demand for healthcare consumption. And the demand is not nearly matched by the resources that are available to provide this increase in need for healthcare. This situation that health systems globally are facing, all types of health systems are facing the same type of challenge, means that more of the same is not going to be enough to meet the demand. In the next slide, we see the drivers for this increase in demand. The main driver you can see in blue is the intensity of care provision and innovation. Innovation in types of diagnostic tests, innovation in interventions and procedures, innovations in new medications. There's, rapid rise in development and in creation of new medications for many types of disorders. On the right side, you can see a number of examples. New diseases, clear and very close to our minds and hearts in the recent past is COVID-19, and new interventions. A common example is diagnostics, and we see that in care provision very, very evidently in the rise in types of tests, whether they're laboratory tests or imaging tests or others. And lastly, the relentless increase in the volume and intensity of clinical practice. The slide also shows that one or among the factors is GDP inflation, and that is relevant, very relevant to emerging economies and low and middle income countries, and demographics, aging populations. Our populations are living longer, and when they live longer, they will develop chronic conditions and they will require more care. The next slide shows that, and this is very close to the topic of patient safety. I'll talk about it a little bit here, and then I'll come back to it as we proceed in this conversation, is the relationship between resources, which you see in the x-axis, and the effect size or the benefit. And you can see that putting more in leads to an improvement and an increase in the benefit, but that at some point plateaus. It's not a linear relationship. The more is better. There is a point in which the benefit plateaus. Next, you can see the harm curve. So as you put more resources and do more, also the harm curve increases. That's, I know to the audience that is interested in patient safety, I'm sure this hits home hard. And therefore, the next point is showing in yellow the point of optimality. Below this point of optimality is underuse or under provision of care or services. And beyond this point is overuse or waste or doing too much of something that is unnecessary. An example is doing more x-rays, repeating an x-ray or doing more of a blood test or something like that. Doesn't lead to an increase in benefit. In fact, it's considered in the domain of waste. And therefore, the point of optimality is where we would like to be in our health systems. Next, you can see the evolution of health and care over time. This slide is one of my favorite slides because it shows over time how health systems have been evolving. One of the things about this is when you start on the far left, you can see that there was initially heavy focus on effectiveness of interventions, drugs, surgeries, etc., and evidence-based medicine. And with time, we moved into cost effectiveness, a focus on quality and safety, and the movement into total quality management, then into efficiency, and lastly, in the era that we're in, which is value-based care or value in health systems. The thing about this diagram is that the health systems don't cancel one paradigm and move to another. It's cumulative, where we continue to use what we learned in the previous years and build on them in a response to the reaction to the challenges that our health systems are facing. And this is the century of value. One of my mentors, that's how he describes it and talks about this as being the era or the century of value. And having a health system that is focused on delivering high value helps achieve and sustain universal health coverage for the population, which is an important aspect of health system design. In the next slide, you see the elements or the domains, and I know this might come in the Q&A session. Having a health system that delivers high value focuses on four domains or four elements or four features. Effectiveness in providing the right services, efficiency in providing health services in the right way and using scarce resources productively, equity, which is very important in providing fair access to services and that they reach the right population segment. We talk a lot about population segments when we speak about value, in that a type of service may be important for a segment of the population, less so for another segment. Even if it's a segment of a larger segment of the population that has a certain condition, such as diabetics. A subgroup of those are people that have a more severe case of diabetes that may require a heavy nursing care or prevention metrics. And lastly, responsiveness and providing relevant to citizens' need. And responsiveness comes, a big example on this is responsiveness to acute threats, such as what we experienced during the COVID-19 pandemic. And on the right, you can see a short reference for this, where we speak about value for money and value for many when we think about the population at large. Next slide shows a special study for this audience today. It's a piece of work that we in the Hub did to examine the movement towards value-based care in the MENA region, where we did a landmark piece of work that focused on the GCC countries and North Africa in exploring where they stand with regards to value-based care. The work included desk research on what's going on in these health systems, and it included focused interviews with various stakeholders in this region, including providers, policymakers, private industry, and academic institutions. The work was very interesting in the sense that, first of all, and I think this applies to the EMRO region at large, all of these health systems are health systems that are committed to universal health coverage. All of these are health systems that, when we spoke to them, spoke about the movement towards value-based care, knew what it was, and gave specific examples on how their respective health systems are moving towards it. The next slide shows the enablers that are required for value-based care uptake. And you can see the diagram on the left, and I'll go kind of in a clockwise fashion. Starting at the top, regulatory enablers. The policymakers need to enable the movement towards value-based care, in which care design is thought about in a new way, a focus on outcomes that matter the most, a reaction in policy to those metrics. The next is data and IT infrastructure. In having a value-based care approach, you need to have good data on the patient population segments, which ones have, which disease, which one need which type of care, and data on outcomes and linking those together. And nowadays, there is a clear and evident movement towards registries, disease registries, and real world evidence of outcomes of care based on real world evidence versus the classic approach that focused on randomized control trials that are done in a very controlled and unreal world type of setting. The next one is workforce, really close to our, no, if you could, yeah, workforce really close to our audience today in the role of workforce, what they do, where they're assigned in the care pathway, and how they do their work in the sense of standardizing approaches. Integrating patient care, very important to achieving high value. And through integration of care, considerations for patient safety issues are of key importance. The next is cost and outcome measurement. And we say measurement of what matters and how it's measured and how those metrics are used. And lastly, financing. Very important, also very relevant to the topic today, in the sense that financing often, in the classic way, pays for care and more care and care for errors that happen in the health system and redo surgeries or readmissions or things like that. The next slide addresses the barriers or the perceived barriers that limit progress towards better outcomes. And I won't go through all of them in detail, but I would just highlight a number of them. In the top right, you can see collection and maintenance of patient data, which is quite important. It's a barrier to data-driven decision-making. In the bottom right, you can see high out-of-pocket expenditure, which is one of the limitations and challenges. And on the very bottom, lack of availability of skilled and optimum type workforce. Again, a very important aspect to the topic on patient safety. In the next slide, I start to link value in health with patient safety. And I think this probably is the most important slide for today's conversation. A high value health system is a feature of the health system. It's not an element. It's a feature of what the health system is doing and how it's designed. And delivering high, and it touches on health and care. It's not only about the care domain in ecosystems, whereas patient safety under that umbrella falls under the domain of healthcare, and it aims at preventing and reducing risks, errors, and harm that occur during a care cycle, whether it's an inpatient care cycle, outpatient care cycle, or other. And having or adhering to principles of patient safety, keeping patients safe, lead to high quality or contribute to high quality care, and in return contribute to good care outcomes. And so that's kind of where the two topics link with each other. An important thing about patient safety is that when a patient is not safe, errors and risks occur, which lead to the need of more care for those errors and risks that occur. They lead to more resource allocation, whether it's workforce or drugs or surgeries or interventions, and leads to more waste when it comes to resource usage. Next, I think if you take us to the next slide, I talk about the cost of harm. And this is from a resource from the OECD, where about 15% of expenditure in OECD countries is devoted to treating the effects of safety lapses during inpatient care. That's only inpatient care. And some of the numbers are on the slide. And so this is a clear link with value in the terms of poor patient safety or harm leads to more cost on health ecosystems where money is spent on the management of that. Next is a case study. This is a case study from Catalonia, which is in Spain. It's a district in Spain. It's an example that's close to patient safety. It's in a hospital setting, and it's really a good case study for us to kind of look at and tease out. And I'm curious to see if you have questions about this or examples that are similar to this. So they started with some key challenges, and the 4 are listed here, and I'll just read the titles. First is to improve staff coordination in the surgical process. And so this is a case study that deals with operating rooms and surgeries. Second is the challenge of reducing surgical backlog appropriately. And we know that this is a bigger challenge now after the pandemic. Third is material management, with the burden of having the right equipment and material in the OR for the right patients at the right time. And fourth, the outcome, patient experience, and the process of booking surgeries and having them admitted and going through the surgical block process information. So what did they do? The next slide shows the intervention. And so they came up with a solution that started with planning and scheduling, and they focused on introducing a digital solution that would assist in planning the scheduling and real-time location for surgeries and operating room blocks. In fact, this solution was done across more than one hospital, where they were able to also exchange resources and have magnified positive benefit. And then third is traceability of materials and implants. And as a result of introducing this digital innovation that helped them deal with the challenge they had high value and an impact on patients, very importantly, clinicians and the hospital at large in terms of resource utilization and efficiency. Next is approaching the end of this conversation and talking about some key insights for implementing value-based care in patient safety. First, patient safety contributes to high-value care delivery. It lowers the cost and improve outcomes that matter the most. Number two, value-based care is a patient-centric or a person-centric healthcare model in which payment follows value rather than activities. It's not payment for more activities or fee for service, thereby promoting better health outcomes for individuals or populations. Third, value-based care and patient safety intersect because they both focus on improving outcomes. Fourth, patient safety is fundamental to delivering quality essential health services. A cornerstone of the discipline is continuous improvement based on learning from errors and adverse effects. Lastly, value-based care, safety, and quality are key elements of achieving and sustaining universal health coverage. With this, I come to the end of this presentation, and I look forward to your questions, your comments, and any examples that you may have.
Thank you, Dr. Reem. Thank you for that presentation. It was incredibly informative. So I encourage everybody to post your questions in the chat box, and I'll ask them one by one. So we've got a first question coming in here from an anonymous attendee. So to Dr. Reem, how can we teach value-based care to frontline providers, and what messages should we send?
I love this question, really love it, because I always say that value is created where the clinician meets the patient, and that's where the magic happens. And it goes from there all the way up to the highest level of the ecosystem in terms of the impact of that. And the knowledge and the mindset of frontliners is an essential enabler or essential necessary element to deliver high value. And this needs to be embedded in continuous training. It needs to be, the frontliners need to learn more about this in the classic modes of education, such as nursing school, medical school, technology school. It needs to be part of their ongoing education, and it needs to be really measured in their behavior, because we know that at the level of the frontliner, that's where most of the waste happens, where excessive prescribing of medications that are unnecessary or tests that are unnecessary. Also, in the mindset on the perspective of outcomes that matter the most. We always can count, and it was a kind of an error, but I think it's a correct error, because we always measure what we do in the clinical settings by counting, where we count number of patients that we see in clinic, number of surgeries that we do, whereas we need to start counting across outcomes that we achieve towards that. Okay, sorry, everyone knows now that I have laryngitis and I think my voice is degenerating by the minute.
No, thank you, Dr. Reem. So we've got a couple more questions coming in. How do you see the coordination amongst different hospitals in Saudi Arabia in sorting out issues such as chronic patient care and bed availability, such as chronic issues in our healthcare system?
That's really a big question, and probably has a very big answer. I will say a couple of words about integration of care. Maybe that's the best way to respond to that. So the healthcare or the health sector transformation efforts are aiming towards integrating care in between facilities and providers. I don't want to use the word facilities because it's not about a place where care happens. It's about the care pathway. And the idea is to create these integrated care settings. In the Ministry of Health setting, it's called they call them the health clusters. In other settings, I don't know what they're going to be calling them. The idea is to provide all of the care necessary for that population through this integrated solution. And with that, we would be utilizing our resources in the best way, particularly when we speak about hospital beds, particularly when we speak about operating rooms, because that's where most of the, when we speak about the expenditure, the resource element in the value equation, that's where most of that is spent. It will be, the care pathways and designing them and solving that integration question is going to be evident to us as the implementation of the transformation takes place.
Thanks, Dr. Reem. And we actually have a question that's somewhat linked to that, in asking about PROMs and PREMs being recently introduced. And I guess the question around it is, why is it being prioritized now, and how does that fit in?
Okay, I really like that question because we didn't speak about that in this presentation, partly because I didn't want it to be like too excessively long and exhausting to the audience. But when we speak about measuring value, it's about measuring outcomes that matter the most relative to the resources that are allocated. And so when we speak about outcomes that matter the most, there is a big movement towards measuring patient-reported outcomes. They're called PROMs or PROs, and patient-reported experiences or PREMs. This movement is a global movement in health systems. When we think about other industries other than healthcare, this has always been the case. We always give the example of hotel bookings or travel. When we want to do, we as consumers or people, we always, when we want to book a hotel, we always look at the ratings. And who does the ratings? The customers or the consumers do that. In healthcare, this has never been the case. And that's the reason that there is a movement towards that. Understanding how to use patient-reported outcomes, which tools to use, how to integrate them with electronic health records is something that's in evolution globally. We think that we in the kingdom and the region have a major opportunity to lead in this. I also want to say something that's relevant to the work that we're doing at the Hub, in the sense that we are thinking about how, because we know that health and care is very local. It's national and subnational. It's very regional and region specific. And we know that experiences that countries and health systems have had are worth us learning from and trying to apply in different settings and new settings, propagate, scale, and accelerate.
Thanks for that. There are two questions that are coming in that I think are quite linked and that you might be able to answer in a kind of combined way. And the first is around how to guide the conversation on value to avoid linking it with cost reduction and rather with improving quality and outcomes. And then additionally, there's another question talking about patient safety and value being on the same spectrum. And the participant wanted to know if that's the sort of correct understanding. So really around the picture.
Okay, so on the first question is, so I already forgot what the first question was.
Cost reduction versus
cost reduction. I also love that question. I really love it a lot. And in the work that we do, we sometimes we overemphasize the outcomes perspective. We know that value is that optimal balance, and that consideration of resources that are used or costs is extremely important to the value equation, if we are to refer to it in that way. In our journey, we've constantly overemphasized the element of outcomes that matter the most, because we know that in the process of improving outcomes and focusing on outcomes that matter the most, as a byproduct, the costs are either contained or reduced or saved or other. And the big example is that Donabedian, the graph that I showed, where more is not necessarily better. In fact, more leads to harm. And more leads to harm not only because we're spending more, but mostly because we are doing harm. And so I really appreciate that question, and that it's not about reducing cost, but the cost and the resource element or consideration is quite important. And we, the clinicians, have not been educated enough about that perspective. And therefore, oftentimes when that conversation about resource allocation comes, we often feel very sensitized and very uncomfortable. And on the second question about the relationship between patient safety and value, I would say, think about value as an overarching feature of the health system. So the health system aims to improve people's health, improve care, contain costs, and that's where, you know, the health system feature is. Under that, we would have health, where people are well and we want to maintain their health, and healthcare, where in case of an illness that occurs, patient safety falls under that, in the sense of applying principles of patient safety, avoiding harm, avoiding errors, falls under that domain. And when we speak about outcomes that matter the most, we speak about quality of life, we speak about, you know, quality of life in relation to a specific procedure or disease, or we speak about burden of care, all of those things. Under them, we have the quality outcomes, and patient safety contributes to high quality. And so that's how I see the relationship between the two topics.
Picking up on that thread, we've got a question in around communicating some of these concepts that can be quite challenging. So the question reads, this individual really struggles to get patients to understand the basics of patient safety values because it's new and there are cultural barriers. So do you see the same issue when explaining value, and especially to patients? And then as a follow-on, sort of how do you tackle that?
That's a great question, and it's a great question because we always say that we're person-centric, patient-centric, but we oftentimes think alone without the patient, do things alone without the patient or the person. And understanding the patient or the person and how to communicate with them in, when we say national, subnational settings, is extremely important. And we, you know, especially the clinical teams, should never underestimate the ability of an individual to make decisions about their own health and care and life. Because when someone is sick, their personal values and what they want out of the care cycle is there. We just have to figure out how to have the right conversation with them. I can do a little storytelling because I was in clinic today, and so I have some fresh stories for the audience today. I've personally evolved with time as I understood this. It used to be in clinic, I would say, patient, you should take this medication. The evidence shows that you should take this medication. You should, and sometimes we give injections. We really preach, tell them you should do this and you should do that. And when they come back in a follow-up visit and they didn't take the medicine, usually we say they're non-compliant, they didn't do this, they missed their appointment, they didn't, and we, naughty patient that did all of those things. But now, as I understand value more, the first thing that happened with me, and that's, my personal story, is I started to listen in a different way to how people describe how they're troubled by their condition. And I also listen carefully to what's important to them to achieve through the care cycle. And sometimes it's in the way they choose the medicine. Sometimes they would tell you, doctor, I can't take a pill every day. I will forget, I know myself, I can't take a pill, give me another option. Or I'm afraid of needles, or, I don't want to be constantly reminded by my condition. Or sometimes I will do anything. Just, I can't go home before taking my medicine. I will not be able to sleep tonight without knowing what's wrong. Or listening to those expressions really is to understanding what is important to the patient. Now, the other thing about us clinicians in responding to that question is sometimes we think that we need to give the patient a lecture in anatomy or pharmacology to explain, the molecules that you'll be treated with. And sometimes that's not the right thing. It's, imagine yourself going to purchase an item from Jarir, our bookstore, and that local bookstore, or an electronic item. You're not going to go and say, well, how does the smartphone work? What's the, how? You just want to understand how it functions. And so in the conversations that we have with our patients, we and this is what I say to my patients, I say, I'm the coach. I can't do the entire experience of having the illness and doing the care with you. I can coach you through this. And I try to narrow down the big anatomy lesson to what makes sense to them, narrow down the big pharmacology lesson to what makes sense to them. I try to coach them with the best options. But I appreciate the question, because this element of co-creation, and that's where, when we speak about healthcare is not, the patient is not a co-consumer. The patient is a co-creator. He or she will be, and their families, in fact, in the region, the families are part of the decision-making and part of the creation of the care plan and what happens after that. And therefore, trying to have the right kind of conversation. And sometimes, and I'm with you, the person that asked the question, sometimes we have to break it into two conversations. Or, in the case, being a neurologist, I can always give examples from my own practices. Sometimes when we talk to patients about long-term medications that they will take, I try not to have this conversation in the inpatient setting in case the person is admitted, because I feel that's not the right place for them to imagine how they will be taking it in the out. So just keeping those in mind, I think, is an idea.
We have an interesting follow-up question to that. Looking at the time you spend with patients, because I mean, obviously, you've just described being very involved in that clinical setting. So the question is essentially asking, when you changed your practice and paid more attention to these patients, do you take more time with them? Because doctors are pressured to see more patients with less time, and sort of how do you balance that?
Great question. Great question, because that's going to how you do value-based care. The clinician, the workforce is a big important resource and should be used to the max for the thing that they are designed to do. Therefore, the physician should do the physician type role, the nurse should do the nurse type role. If we need a coordinator, we assign a coordinator. If we need a lower level, someone clerical that does the booking or something like that. That's where, when you split the roles among the different team players, that's where you can maximize the amount of time that is required to do the counseling. In the case of outpatient care, also understanding to answer that question, and also in how it applies to my own practice, is I know that the first visit needs a lot of time because I know what's in it. I know the curriculum or the agenda items on the first visit. They are heavy and they require more time, more explaining. And I usually also agree with the patients on what's going to happen next. I say, well, next visit, the agenda is, I will ask you this question and you will ask me this question. And the next visit is going to be for 5 minutes. And guess what? I also think about the inter-visit intervals, which is an important aspect about value-based care. We often think that more visits are better. Again, more is not always better. And so even in the case of a disease such as diabetes, what's the optimal number of visits to see a physician? There is no standard. You need to segment and tailor this to your patients. Some need to come more often. Others need a longer visit, potentially in the beginning, and then they're on their own. And they can come less frequently. They can have touch points with the coordinator where they review their disease control. That is really a great question. And that really, every practitioner needs to think about his or her specific setting for that.
So zooming out a little bit, one of the questions that we got was asking who are the responsible stakeholders to evaluate the value of a system. How high value is it? How low value is it? What does that ecosystem look like?
Great. We were, Terrina and I and our colleague, we were just at Harvard last week, where we spoke a lot about this perspective. We spoke about high value health systems and how you evaluate them and how you can judge which health system is, delivering high value. Well, the first thing to say is that there's no perfect health system. Remember, and if there's a message I'd like you to leave with, is there's no perfect health system. And when you look at health systems, they have areas of strengths or advancements. And all health, the other thing to say, which is something that I'd like to leave you with, all health systems are in evolution. It's not in a static, it's not like a building that's fixed with what it looks like. All health systems are in evolution with the innovations, the challenges, the diseases, whatever it is that is happening. And there are multiple domains to consider in assessing health systems for their value delivery. And in assessing that, one thing would be like the availability of digital data solutions, disease registries, the measuring outcomes, measuring and understanding costs, paying for performance, paying for value, policy making, the entire ecosystem. There are many domains that contribute to the assessment of a health system that is high value. And so that's what I would say in response to that.
Fantastic. And so we have a follow-up question inquiring about whether value-based care can be implemented in a single facility. So the setting.
Another great question. Wow, we have such a great audience today. So value-based care or value or high value, I mean, I prefer sometimes not to call it only value-based care, because value-based care sometimes constrains that definition. It applies to every setting. You know, it applies to a single hospital setting, applies to a single primary care or clinic setting, applies to integrated care setting, health cluster or an ACO, or a nation. And in a hospital setting, you can think about specific segments or population groups. Specific population groups that you deal with. I mean, the example I gave in today's presentation, I thought would be really close, because you're thinking about people that are coming to have surgeries, and it could be an elective procedure, knee replacement. People with knee pain would be an area where you would focus on, and you would think about improving value. And improving value starts with rephrasing that question. It's not about knee replacements. It's about people with joint pain, and thinking about which ones need to have, which ones absolutely need to have this knee replacement, which ones need to have it first, how to improve the efficiency of the process of actually doing the knee replacement, thinking about allocating the right resource, you know, the importance of like post-surgery rehab, or other things, redesigning that care cycle, and thinking about where your resources are allocated. Your human, especially for clinicians that don't deal with you know, the actual funding for specific solutions, but thinking about where you allocate your human resource is a very relevant area. So you can deliver high value without actually influencing or changing your hospitals or your CEO's overarching strategy. You can impact that change in your own setting beyond doubt.
So I think we have time for one or two more questions. And the one, probably second to last question that I have for you is around low and middle income countries and their relation to value-based care and patient safety. I know this is something that you wanted to touch on a little bit.
Yeah. And, you know, it's really an important question, because oftentimes when we speak about value or high value health systems, the impression, just like the question that we had about the cost, but the impression is, oh, that's only what high income countries are dealing with. Because they have, you know, digital solutions and, you know, and platforms and this and that. But the answer is that this applies to all health systems. High income countries, emerging economies like, you know, my country, Saudi Arabia, low income countries, particularly low income countries, because the resources are more limited. And therefore, considerations for equity, considerations for access, considerations for quality is extremely important. And in relation and how we link it with patient safety, I think is extremely important. It would be a catastrophe if you have a low-income country that keeps, you know, paying for, and we learned about this, we also learned about this last week at the Harvard event, where one low-income country was very busy doing surgeries for amputations for people with diabetes. And it's not about doing a perfect surgery that is, you know, efficient and speedy and low, you know, number of days in hospital. It's about thinking about the big picture. I mean, I can do faster and quicker and cleaner amputations, but that's not really what we would like to do. And therefore, considerations of the right care for the right person in the community at the right time is more relevant to low-income countries. And lastly, I want to say, a last word before we close is that innovations in low-income countries are incredible. And, we talk a lot about the example in Kenya where they used WhatsApp to solve postpartum complications in women. And that is totally and completely incredible and something we can all learn from.
I think it's going to be really interesting to see some of these case studies come to life. I know the paper that we're working on with Harvard will really highlight some of the things that you're talking about. We have one last question before we close, talking about building KPIs around value-based care. How much change is required and needed to place that in potentially a balanced scorecard? So talking a little bit about the metrics there.
That's a great question. Now, KPIs in healthcare have also gone through like a whole evolution cycle. More is not necessarily better. And we know that many clinical entities, clinical teams are busy collecting and reporting on a large number of KPIs that not all are necessarily relevant. Maybe some of them could be a proxy for others. Some of them could be just process-related type of KPIs. And so the metrics, and I prefer to call them metrics, are the basic value metrics. And they're outcomes that matter the most to the people and the population relative to the resources that are invested in there. And there needs to be a dashboard, and that's some of the work that we're doing in our national center, is thinking about what would the minister's dashboard look like for a high value delivering health system? What would be included in there? What specific metrics for health outcomes and patient reported outcomes at the national and the mega, the macro and mega level would be important for His Excellency to look at, and what would be in it. And I think that the precise answer to that is still in evolution, but we are working towards it.
Thank you, Dr. Reem. I'm super happy to say a big thank you to the Saudi Patient Safety Center for inviting us to speak, and to you, Dr. Reem, for sharing all your wealth of insights around this topic. From what I understand, the session will be uploaded to the Patient Safety YouTube channel, and the link is in the chat box. And other than that, thank you all for joining.